We know that errors or safety incidents, as they should be called, are very common, and some of the headline figures are here. But it's the complexity really lies in measurement, and it depends on what you mean by a complication or a patient safety incident in terms of broadening what we mean. This was work that Manmeet did with us, published a few years ago now. And if you just don't worry about the bars on the right-hand side, but just look at the safety incident categorization. So these were incidents that were identified in our unit at St. Mark's in routine lists. They didn't necessarily result in harm to the patient, but they were there. COVID really changed things for all of us, and it highlighted a number of issues. Firstly, pre-COVID, you had a very cohesive team. You literally worked very closely together, and communication was probably good, or as good as it could be. COVID changed things. We literally had to be further apart. We had masks in front of our faces, and that was a barrier to communication. And we developed and published an endoscopy toolkit, which was pertinent to COVID, but it drew out a lot of issues for us about improving our whole team huddle at the beginning of the day, the list briefing, and importantly, the debriefing, and also how to optimize communication. So yes, this is about communicating with a face mask on and maybe, some of the more onerous PPE, but it is relevant, I would argue. If you're checking drugs, going through the checklist, and you've got a mask on, obviously errors are more likely to happen.
But I wonder whether, sort of saying we need to get an interpreter kind of here to help out with that discussion is the right thing to do.
Mm.
Can we ask what nationality the patient was?
Indian.
Because the reason I asked that question is there are cultural differences in terms of control and expectations and everything else. And, a patient from a different country, maybe a European country that didn't speak English, might react and behave very differently from a patient who doesn't speak English from Asia. Okay,
yeah. So I think not so much control perhaps, but, protection. They were very protective of their mother and wanted to make the right decision for her. But
it's also the mother expecting someone else to make the decision for her and being quite happy with that. Can I just make one observation? I've done a lot of work, believe it or not, with a psychologist who was very interested in consultations in primary care. And one of the studies he did was looking at what patients wanted from the shared decision-making conversations. And broadly speaking, patients fell into three roughly equal groups. So one group was, I want you to make the decision for me. Okay. I don't want to know anything, Secondly, I want to share the decision with you. I want to have a discussion about what's going on, and then we come to a conclusion. And the third group wanted the information and wanted to make the decision. Okay. So patients, and I use that in my consultations a lot when I was doing outpatients, and, that information from primary care may not be directly transferable to secondary care in terms of the proportions, but I think the qualitative message that I think there's something about saying to the patient, do you just want me to make the decision?
So sadly we've got a little bit of fluid leaking in, and I haven't got any CO2.
Can I, while you're just sorting out the CO2, make a point about Steve holding the scope there, is that even with fantastically experienced nurses, if you're lucky enough to have another endoscopist assisting you, that is almost always better, because they will intuitively keep the polyp with scope rotation, shaft rotation in the right plane for you, and will adjust and will know when to hold the scope, let go of the scope, when you want to take control. And very experienced nurses will do that. But if they're an endoscopist, and it goes back to what you were saying, Roland, about going and watching a colleague, actually going and scoping with a colleague, if you get them to assist, it just helps tremendously. And I'm sure for a lot of the advanced therapy, ESD and so on, that's also the case. And the second thing is that Steve is on the same side as John. So quite often you will have a nurse who you say, can somebody hold the scope, and they'll hold the scope from the opposite side of the bed.
Yeah.
And then when you say twist towards the screen or twist away from the screen or twist anti-clockwise or whatever your terminology is, you're opposite already, which breaks down a level of communication.
Yeah.
So if you're going to get somebody to hold the scope, ideally, I would say, have them on the same side of the bed as you,
through.
and
Okay, you ready?
ideally have it as an endoscopist.
And you have to develop the relationship with the person that you're working with in the room for life, which is very different to day-to-day practice, but nevertheless, it's relevant to your question.
So there are guidelines. There are, I'm sure geeks are following them. There are guidelines for those of you who want reassurance, published by the ESGE on doing live endoscopy. And it is a topic that we come back to as to, is there benefit of doing something live as opposed to seeing pre-recorded videos? But there are additional levels of safety, as you say. Some units will have a patient advocate who's none of the people on the screen. They're just not on the screen. So there should be a patient advocate, ideally, who is around to make sure that procedures aren't overly prolonged, that things that wouldn't normally be being done are being done, that the patient is adequately consented.
I think it's another thing as well, and that's empowering the nurses to challenge and to say if there's a problem or to say if there's an issue. So I love it when nurses come to me and say, do you know they're on sort of clopidogrel? I usually do know, but actually I have no problems in being reminded because, I may forget or have a complicated case so it's, but not every nurse will kind of...
In that situation, I say to the nurses, thank you, and remind me again in the case when I say, can I have the snare, please?
Yeah.
Because if it's a difficult intubation, you've got a 15-minute traumatic intubation, and then you've forgotten what's happened at the checklist. So you need that flag.
Yeah, I think thanking them, because that encourages them to do it again, and it gives them permission. It's a form of empowering. But I think it's the general culture. It goes back to that culture thing.
Absolutely.
Is what is the hierarchy like in the unit, and how comfortable the nurses generally feel with the medical staff. And I think it's a great concern if one of them or one of the medical staff they're frightened to challenge.